I am writing to summarize a well-documented pharmacokinetic issue affecting the clinical response to levodopa, carbidopa, Sinemet, namely the interaction between levodopa absorption and dietary protein intake. This issue has direct implications for motor fluctuations, delayed ON, and reduced therapeutic reliability in Parkinson's disease, PD. I have had this disease for 7 years, and I have never been advised by anyone of the serious nature related to the absorption and dosing of Sinemet. I have only found out by taking an online neuroscience 3-part specialization course from Dartmouth College to better understand my illness and what I may do to slow the progression. I am disappointed to find out that I have never been informed of this critical fact by any physician or pharmacist. Mechanism of interaction. Levodopa is absorbed in the proximal small intestine and transported across both the intestinal epithelium and the blood-brain barrier via large neutral amino acid, LNAA transporters, LAT1. Dietary proteins are digested into LNAAs, e.g. leucine, isoleucine, valine, phenylalanine, tyrosine, which directly compete with levodopa for these transport mechanisms. This competition occurs at 2 clinically significant sites. 1. Intestinal absorption. Protein-derived LNAAs reduce levodopa uptake from the gut, lowering plasma levodopa concentrations. 2. Blood-brain barrier transport. Elevated circulating LNAAs further compete with levodopa for CNS entry, reducing central dopamine availability despite adequate peripheral levels. Carbidopa mitigates peripheral decarboxylation of levodopa, but does not affect LNAA transporter competition. Clinical consequences. Protein levodopa competition is associated with delayed or failed. On responses, reduced peak dose benefit, increased dose-to-dose variability, worsening motor fluctuations and off periods. These effects are especially pronounced as Parkinson's disease progresses and gastrointestinal motility becomes impaired. Timing recommendations. Administering levodopa at least 30-60 minutes before or 60-90 minutes after protein-containing meals improves bioavailability and clinical consistency. Many patients benefit from a protein redistribution diet, concentrating daily protein intake in the evening to preserve daytime motor function. Supporting evidence. This interaction is well established in both experimental and clinical literature and is referenced in movement disorder treatment guidelines. Conclusion. The levodopa protein interaction is a predictable transporter-mediated pharmacokinetic phenomenon, not patient noncompliance or disease variability. Attention to meal timing and protein distribution can significantly improve therapeutic response without increasing dose burden. 1. Pincus J.H., Barry K.M. Influence of dietary protein on motor fluctuations in Parkinson's disease. Neurology. 1987. 2. Nutt J.G., Woodward W.R., Hammerstad J.P., et al. The on-off phenomenon in Parkinson's disease. Relation to levodopa pharmacokinetics. N. Ingle J., Med. Dietary, 1984. 3. Leanders K.L., Poe W.H., Palmer A.J., et al. Inhibition of LNAA transport reduces levodopa brain uptake. Onen Neurol. 1986. Katz Threda E. Baricella M. Pedroli C. et al. Low protein and protein redistribution diets for Parkinson's disease patients with motor fluctuations. Neuter Neurosi, 2010. 5. Contine M. Martinelli P. Pharmacokinetics of levodopa, J. Neurol, 2010.